Hey, good evening, everyone. Welcome to the Foot Forum over at Seaview Orthopaedics. Sorry for the technical delays, but there are always something. I'm Dr. Aron Green, foot and ankle surgeon, orthopedic surgeon out of Seaview Orthopaedics and Medical Associates, and we are starting a new series. So this is the first episode in the inaugural season of the Foot Forum, where we'll be discussing lots of topics on live feeds about conditions of the foot and ankle that are presently evolving. One of the conditions that's really gotten a lot of playtime, both in direct to consumer marketing as well as in media, is bunions. And that's going to be tonight's topic for our evening podcast. Perfect. So basically, we're going to look at bunions past, present, and future. So if you look at history, there are over 100 different described bunion surgeries, and more seem to kind of appear every year with different hardware and different technologies that are trying to make the procedure easier, more reliable, more reproducible. Newer equipment and technology has definitely advanced the science of bunion surgery and made life of both surgeons like myself and patients markedly better and easier. We're noticing that recoveries are faster and outcomes are better and more reliable. However, what all of this should tell you, especially the fact that there are over 100 described procedures, is whenever there are multiple different surgical procedures for the same problem, none of them all work particularly well. So that is definitely an issue with bunion. Has historically very much been an issue with bunion surgery in the past. Um, Again, everything old is new again. There's some new procedures coming out that have been actually done for a while, but are coming back into favor because hardware and technology and engineering has finally caught up to some old and very, very good concepts. And the real take-home message about this that we've really learned from looking critically at the history of bunion surgery is that there are in fact different types of bunions, and all those different type of bunions require different types of surgery. And historically, bunion surgery has always had a very bad rap, for lack of a better term, with pain and recurrence rates. And in reality, from a pain perspective, evolution in anesthesia has really changed the pain perception post surgery, and our understanding of different bunions require different types of surgery is really substantially decreasing the recurrence rate and kind of the failure rate with bunions. So, what is a bunion? A bunion is in reality just a painful bump on the inside of the foot. It's not a growth, it's not new bone that's forming, but what actually happens is your native metatarsal, your native bone, your normal bone starts to change its position and either sublux or even frankly dislocate at that big toe joint. The longer it is not in the position that it was supposed to be in, the more arthritic it will become and ultimately cause more forefoot deformity, leading to either hammer toes or fat pad atrophy and pain at the level of lesser toes, and not really pain just at the level of the bunion or the big toe or the hallux. And this is just schematically looking at it, kind of a picture of what a bunion is. On the left, you can see what a normal foot is and normal alignment is, and on the right, you can see the metatarsal swinging out to the side, causing that painful bump that rubs against shoes and actually causes the toe to actually rotate a little bit, and that just starts to become arthritic, and then it leans up against the second toe, which can cause the second toe to pop up and lead to lesser toe pathology and lesser toe problems and further shoe wear problems. So there are different types of bunions. The one type of bunion is congenital, and you see that generally in teenagers and mainly teenage girls, much higher preponderance in teenage girls. These are bunions that are generally genetically driven. You're just meant to have a bunion. They're relatively difficult to treat for the simple reason God, Mother Nature, whoever designed us, designed you that way and wants to keep you that way. So those bunions tend to have a very, very high recurrence risk, or they tend to recur. So we generally wait until skeletal maturity with closed growth plates to fixing those. The most common bunion is an acquired bunion. So it's a combination of genetic factors and environmental factors. The AOFAS, which is the Orthopedic Foot and Ankle Society, did a study in the 80s that showed approximately 88% of women at some point in time wear inappropriate shoe wear, and that definitely does contribute to having a bunion deformity develop. There can be traumatic bunions. Those are bunions where there's a trauma to the big toe and there's capsular damage to the big toe, and that can lead to a bunion. Neurogenic, can see post stroke or various other neurologic problems that lead to muscle imbalance, causing a bunion, and these tend to be bigger bunions and more severe bunions. And then syndromic, like autoimmune conditions like rheumatoid arthritis, frequently lead to bunions and other forefoot pathology. Here we have different level of bunions, and going from left to right, you can see a mild bunion, which is a little bit of a bump, which is not so bad, but definitely can be very symptomatic and very problematic. Progressing to moderate, large, and then really severe bunions, where you can see the big toe or the hallux has moved all the way over and actually just popped that second toe up. So that second toe is dislocated and kind of just sitting on top of the foot. And from what I kind of call it, as being functionally amputated, because that toe hasn't probably touched the ground in 5, 10 years. And that's the general progression of a bunion. The ideal time to fix a bunion, kind of looking at this bunion severity scale, is the day a bunion starts to become symptomatic. The day a bunion starts to become symptomatic is the day that that bunion is starting to become arthritic. And that's the exact right time to fix it, because you'll have a good outcome. The longer you wait, the more arthritic that bunion is, the less successful the outcome will become, because you'll always be left with a little bit of residual arthritic symptoms, or a little bit of continued pain afterwards because of the arthritis that is present at the level of the bunion. Okay, so I got a bunion. Now, what do I do about it? The easy answer is, and I tell all my patients this: if it doesn't bother you, it doesn't bother me, and you don't do anything about it. Again, just as in the previous slide, the right time to fix a bunion is just when it starts to bother you. So when it does start to bother you, always try non-operative management first. You really want to do shoe wear modification. You want to make sure that you're wearing appropriate shoes with a wide toe box and something that really does accommodate your foot. You want to try activity modification to try to see if there is a particular activity that is inciting bunion symptoms, and try to modify that as well. Again, the AOFA study from the 80s really did show that a lot of bunions in the adult population, the acquired bunions, are really due to true shoe wear issues and wearing inappropriate footwear. However, frequently, and especially with time, when that doesn't work, you start to venture into your surgical options. Surgery has a bunch of different options. Again, we discussed in the initial portion, in the initial slide, there are over 100 different described bunion procedures. So generally, from a surgical perspective in the industry, we talk about distal procedures, or those done closer to the joint, those done somewhere in the middle of the bone, those done at the level of the proximal portion of the bone, more to the level of the midfoot, maybe just soft tissue structures like ligaments, fusion surgeries, minimally invasive surgery, which has become very, very popular now for good reason, or even some bunions require a combination of different procedures to really um, fix the problem. When you look at distal surgery, this is traditionally a good procedure. It works for mild to moderate bunions. Um, you go in, you open up the capsule on the inside of the foot. Initially, to fix a bunion, people just shaved off the bump. That had a 100% recurrence rate, because it didn't correct the underlying deformity. You just took a little bit of the bump off, and the deformity just kept on getting worse with time. The workhorse of a distal procedure is the distal chevron. It's really the traditional procedure. Again, it was always kind of, you cut the bone, shift it over, and fixate it with a fixation of choice. Usually, historically, which is just a K wire, which is a little small metal rod that we usually are sticking through the skin, that gets pulled out somewhere around post-op week 4 to 6. However, newer implants and newer technology is allowing for earlier weight bearing, and a less painful and just a much more mild and quicker recovery. Once you get into somewhere in the middle, which is the middle of the metatarsal bone, you can see two different procedures described here, both the scarf and Ludloff. Those really were very popular in Europe during the late 90s, early 2000s. Not really traditionally done in the United States, and on many levels have become just of historical interest because not many people are doing them. They're technically very difficult procedures with moderately successful outcomes. There's recurrence risk, there's fracture risk, there's hardware symptom risks. Again, the middle options really fallen out of favor because it didn't work. It was too aggressive for small bunions and not big enough for big bunions. And very rarely did you get that Goldilocks type of bunion that just worked for this. Moving more proximal, historically, proximal osteotomies and proximal surgeries were reserved for your bigger, your major and severe bunions. Again, it's kind of a geometry physics thing. The closer you are to the center of deformity, the more of a deformity you can correct. So every millimeter of correction proximally equals probably like 6 to 8 degrees worth of correction, whereas every millimeter of correction distally is equivalent to 2 or 3 degrees. So you can really get much larger corrections. The problem is they are have larger or longer recoveries. There's more pain. They're bigger incisions. Each of these procedures generally has its own unique complication profile. So there's a learning curve associated with it. But in the world of big bunions, they're the true heavy lifters of the bunion world, and are still very good surgeries for big bunions. From a big bunion perspective, a surgery that became very popular in the late 2000s and early 20 teens was the proximal opening wedge, where you cut the proximal metatarsal and then put some form of appropriately sized wedge that would straighten out your metatarsal. And you can see pre-op on the left, post-op on right, where that wedge just kind of levers out the bone and straightens it. In reality, it seemed like the great procedure because it really technically was very easy. It was not a complicated surgery at all. The problem became when looking at results approximately 5 years out. So the midterm results showed greater than 50% recurrence rate. So not ideal because that means a lot of these bunions did come back. Um, n- there's a lot of speculation as to why they came back. There are definitely different factors. But again, this procedure really became very popular and then very much fell out of favor very quickly because of it. Proximal closing wedge is of historical interest. It was a very popular podiatry procedure, not necessarily an ortho procedure. It worked very well. The issues with it is it did shorten the metatarsal, which created some lesser toe issues and other laterally based forefoot issues. There's really no new constructs, and at the end of the day, really has a complication profile because of poor fixation, and the osteotomy can shift and not commonly done anymore these days. Proximal crescenteric is another good old school operation. It's where you cut basically a crescent shape in the proximal metatarsal and that lets you move the metatarsal pretty much any which way. So you can move it varus into varus or valgus, you can move it dorsal and plantar, and really get a good correction. The problem becomes it requires some very unique equipment and basically very specific saw blades that only work with specific power sources that are rapidly falling out of favor because they're no longer made. They rely on essentially a single screw fixation, which isn't the most stable of constructs, which leads to some significant problems with weight bearing and non-union. You can have dorsiflexion non-unions and a very specific complication profile associated with this procedure. Still a good surgery, but again, falling a little bit out of favor. Proximal chevron, great surgery. Technically, very difficult to do. Fixation is difficult. The fixation generally becomes symptomatic, but again, very effective at fixing big bunions with a very low recurrence rate. Back in the 80s, 90s, and early 2000s, this was primarily the orthopedic big bunion procedure, and it worked very well, but it's fallen out of favor due to lack of new equipment. Also, just it's technically a difficult surgery to perform well. And then you have the real workhorse in the podiatry world, which really did become very accepted in the orthopedic world towards the late 2000 noughts and the early 2000 teens, which is the Lapidus. This is a very powerful tool It is joint sacrificing. It's actually a fusion of the first TMT joint. So you're losing motion of that joint, although that joint doesn't have a huge amount of intrinsic motion to it. Um, but very, very powerful. You can get a huge amount of correction. You don't have to worry about progressive instability at that first TMT joint at the level of the midfoot. It's a very, very durable surgery. It's very good for salvage procedures and for revision procedures where you're dealing with the recurrence from other surgeries. The problem becomes it's a big scar. It is a long recovery of not putting weight on the full foot, and can be a little bit painful just because of the size of the scar. Historically, it has a relatively high complication rate when you look at the literature from the 40s and 50s. But as equipment has improved, that complication profile has really substantially decreased, where it really has an acceptable complication profile and is a good surgery. To augment any of these procedures, you have a osteotomy called an Akin, which is a proximal phalanx osteotomy where you actually do a closing wedge of that proximal phalanx, and it allows you to kind of fine tune the position of your hallux. So if you still have a little residual deformity after doing your metatarsal work, you can really fine tune to get the position you want. So you can see here a fairly big bunion that had a distal chevron done with that screw in the metatarsal head, and then just to fine tune position because there was a little bit of hallux valgus interphalangeus, there's still a little bit of residual bunion deformity. We straightened out the phalanx with an Akin there, and it's a helpful little adjunct procedure to get to help with procedure to help the procedure be successful. And then you have the star of the show, which is minimally invasive. So this is a technique that has actually been around since the 60s. It was first reported out of Italy in the literature back in, I think, 1964 and 1965. So it's really not really a new technique. In reality, now we're probably on our fourth, depending upon who you ask, maybe fifth generation of technique and implants. um, every 10 years it kind of gets a bump in attention, and that bump in attention really seems to be here to stay now based upon outcomes. The equipment and the technology really keeps on getting better for it. The reality of it, it can be used for all kinds of bunions, so that kind of makes surgeons' lives easier because you it takes a little bit of thought out of what procedure am I doing for this type of bunion. It really does seem to be relatively agnostic as to what kind of bunion you have. From a surgical perspective, the bigger your bunion, the technically easier this procedure is. The smaller your bunion, it can be a little bit more challenging. It still works. What we're finding is there is a fairly significant learning curve associated with it. So from a surgeon perspective, there are training courses that need to be done, and there is definitely a society of minimally invasive bunion surgeons that's very, very active. So you want to have a surgeon that's very, very comfortable doing an MI approach. But the beautiful thing about this is there's really minimal to no recovery, and it's taken a procedure that historically has a very, very bad reputation and really has turned that on its head and really eliminated all those horror stories associated with pain and those horror stories associated with scarring and scars and things like that. So we're finally getting to the point where this is becoming very, very relevant and a very good procedure. So this is probably, if you would look, a third generation type MI procedure where you have two screws fixating the metatarsal or going through the metatarsal. And you have an Akin done on this as well to fine tune positioning. Newer techniques and newer equipment is allowing for a single screw construct, and those better engineered and better designed implants allow for essentially immediate weight bearing on your foot. So it really is very, 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 very good to be a bunion patient now because we can get you up and walking on it the next day. New development. So this is actually one of the projects I'm actively working on. So you see right and left bunion on the left, and you can see that right and left bunion corrected on the right. There's actually hardware in there. This is a new technique that we're calling the MIA bunion, so minimally invasive, and then also play on missing in action. There's manufacturers that are producing essentially synthetic bone type screws and synthetic materials that have the same modulus as bone, that eventually get over a period of 2 years completely replaced by your own native bone. So we're able to cut the bone, fixate it with these implants, which are radio opaque. You don't see them, or sorry, radio lucent. You don't see them on X-ray, and then they get replaced by your own bone over a period of 2 years. And this is kind of, I think, the ultimate evolution of what minimally invasive bunion surgery is going to be. Right now, these implants don't have the strength to be a single screw or a single implant type construct. You do need to implant two. But again, I think this is really when I started doing minimally invasive bunions, I started doing this kind of using hardware that was not really meant for this, but you could use and make work, to now specifically design hardware meant for this and really works very, very well. So I think this is kind of where this technology and where this procedure is going to ultimately settle in the next year or two. Other factors, definitely improvement in anesthesia. We're now doing regional blocks where we numb people from the knee down. That numbness will last 20 to 40 hours. So there's really no appreciable postoperative pain. There is no general anesthesia. That elimination of that immediate post-surgical waking up pain really does change that pain perception. So there isn't this historically painful procedure. People go, yeah, I feel like I have a cut in my foot. It's sore, but definitely not horrible. And then you have to worry about complications such as recurrence, non-union wound issues. Some people have continued pain mainly because the bunion was kind of left there for a while, and those joints are pretty arthritic, and you're dealing with an arthritic pain. You have symptomatic hardware, and you can have non-union. And again, these are essentially all the complications you have. All of them are treatable. You just need to have a surgeon that's comfortable doing these procedures with good track record of good correction, and knows how to deal with problems when and if they arise. And I think that is completion of overview of bunion. Hmm. So starts our question and answer portion. I have my two lovely assistants here, Jerry and Ms. Gibson, Michelle. You're ready to help any questions that have arisen. I don't think you want to hear me sing the Righteous Brothers into the mic, even though I'm so while waiting for any questions if they arise. A little bit about Seaview. So Seaview just opened two new offices. Our most recent office is in our main home of Ocean Township. We finally just opened our Route 35 facing office, just north of Alaire Avenue on the southbound side of Route 35. So that just opened what, about a week and a half ago, if that. We open on Monday. Sorry, Monday. So brandy new, marginally older, but I'm not sure if the paint's actually still dry, or if the paint's dry. Is our East Brunswick office, conveniently located just off of Route 18 in East Brunswick, in between Riders and essentially Riders and Rouge Lane. As a Rutgers boy, that's home turf for me. So we just opened up in that market. And then for our other northern offices, we have an office in Monroe. We have an office in Homedale, right on the Hazlitt border. If anyone knows Dearborn Farms, excellent food just across the street. And our historical home base in Freehold, with two offices there. Soon to be relocating a little bit down Route 9. Down Route 9. So that's hopefully within the next year to 18 months. And then we have our southern offices in Brick, which needs to get more love, and Barnegat. This is our first one. Any comments, criticisms, things you'd like to see in episode 2 of series 1 of this inaugural session of Foot Forum? Any type of input is greatly appreciated. Again, anytime you have questions, we're happy to have. I see a question pop up. Yay, not crickets. Do you think modern shoes are harming our feet? So I think it depends upon what you mean by modern shoes. I think if you're talking about fashion footwear like Louboutins, Jimmy Choos, and all of those, yes, no, those are not really designed for anything resembling a Homo sapiens foot. I think if you look at athletic footwear, no, I think athletic footwear is definitely just like bunion technology. Footwear technology is really developing by leaps and bounds into much more efficient footwear. So if you look at running shoes, there are shoes that definitely are energy storing, conserving, that really do account the normal human gait cycle, and are definitely beneficial. That being said, you get into a whole argument of shod versus not shod running population. So if you look at, and this is really a marathon or a marathon running type discussion, where you see a lot of the runners coming out of Africa historically have trained without shoe wear and do very, very well and have very, very low prevalence of foot pathology. You don't see stress fractures. You don't see the typical problems you do see in a shod population. Again, a lot of that comes down to genetics. The genetics are different to that population. When you do take a population or a genetic population that is not accustomed to barefoot running, and you do put them in minimalistic type shoe wear, you do see a lot of pathology. You do see stress fractures. You do see the development of plantar fasciitis and problems. So, as a whole, do I think modern shoes are harming our feet? Not so much, but I think you have to just be smart about what footwear you choose. There are definitely some manufacturers that do a markedly better job of designing shoes than other manufacturers. You have to be very, very careful and look at manufacturers that are very, very consistent about keeping the same last, and the last is the bottom or the actual sole of the foot, because people get used to using a certain shoe and a certain last, and then all of a sudden the next model comes out. Some brands will completely change the last. Other manufacturers are very, very good about keeping that last within that family of shoes. So I think you just have to be a informed consumer about what shoes to get and what to use, and wearing appropriate shoes. Oh, I'm just I got that one. Please narrate. I mean, there's definitely differences in training. Podiatry is 3 years of schooling. I did 4 years of med school, 5 years of residency, and then a dedicated foot fellowship. Orthopedic surgeons are definitely much more comfortable with using hardware, because that's really, we're trained a ton in that. We're also very comfortable with bigger procedures. While I'm called, I still do hip work. I just still do general ortho trauma work. So there is a little bit of there can be a little bit of difference in skill ability and comfort level with certain conditions. Great question. So one, until you're off all narcotic pain medication, but for most of my patients, they're never on narcotic pain medication for a minimally invasive bunion. They're essentially on Motrin and Tylenol from day one. I generally say once you're back in a normal, regular shoe, such as a sneaker. So I don't like anyone driving when they're still in a walking boot or a post-op shoe. But once they've returned to a normal shoe, either a loafer, sneaker, or something like that, that's when driving is for me fair game, and that's usually 4 weeks. Although some people can be much, much quicker. So yes, that goes back to a run over our initial slides. There is definitely a risk of recurrence for a bunion, and a recurrence is where that bunion comes back. If you look at the overall literature, the literature will say all comers have about a 5% recurrence risk. There are some procedures that are have a higher recurrence risk, as we went through that opening wedge osteotomy, seems to have a settled into a solid 50% recurrence risk in the literature. When you really boil it down, the vast majority of recurrences are again doing the wrong procedure for the wrong bunion. So trying to cheat and do a distal procedure for a really, really severe bunion, that's just never going to work. You may look good for the first 6 months, but you know that bunion's coming back. So historically, that's really where you see a lot of your recurrences from. But right now, with someone who's well trained, well educated, who knows what bunion you have and what bunion surgery you need to fix it, no, the recurrence risk is very, very low. So personally, not affiliated. I very much do think Brooks and New Balance are very, very well designed sneakers. And again, going back to that whole conversation about last, they're both very, very good about keeping the same last through their entire line. They're not necessarily sexy shoes, but they are very, very well. They don't have the appeal of the Nike swoosh, but they have a very, very well designed portfolio of shoes for different types of foot structures. They have structure shoes. They have good shoes for pronators. They have good shoes for supinators. They actually have again, the whole concept of speed shoes with carbon fiber springs designed in them for energy storing and reusing. Though I generally find those are I think two of the better brands. Additionally, I generally find running stores that stock those have knowledgeable staffs that will be good at fitting people who don't necessarily have off the shelf feet. So two things. So hookahs are really thicker soles. I think if you have, yeah, hookahs, yeah, no, hookah. That's after this. But no, hokas, I think for people with plantar fasciitis is very good because they do offer a substantial amount of heel cushioning. However, you get to a point where there's actually too much cushioning, and that can throw a biomechanically not normal foot a little bit off balance and cause it to work harder and to lead to other problems. But I think if you carry a diagnosis of heel pain or plantar fasciitis, they're really, really good shoes. The other thing that you're seeing with these really aggressively wedged back shoes, those are speed shoes. Those are marathon shoes. And those shoes are designed with a carbon fiber last in them and a carbon fiber back that essentially acts as a spring so that when your heel lands, it stores energy to actually propel you forwards. So if you actually look, that became a huge controversy in the running community because people were setting PRs and world records on these shoes because yeah, they're engineered to just one be faster and have you work less hard so you have more energy to run faster. It is a good thing depending upon your governing body, but yeah, no, so that's the thing about those really, really big heels. Cool. I think just to give our foot forum a little shout out, I think next episode is going to be in 2 months at the end of May 27th, and it is going to be Achilles. So questions were great. Get those questions written down. So we'll have a lot to talk about. If you need to come see me in the office, I am pretty much at all of our offices except for Barnegat and Monroe. Feel free to make an appointment. Feel free to call our marketing team to make an appointment. Seaview Orthopedics is always around to help with all of your orthopedic needs. We have everyone to accommodate from basically birth to death to handle your orthopedic needs. Thank you so much. Have a great night.